بسم الله الرحمن الرحيم. أنا الدكتور عمرو خيري، رئيس قسم العظام جامعة عين شمس، و في سلسلة من البلاتفورم بتاعت جامعة عين شمس. It is my pleasure to introduce to you our fourth عين شمس webinar in our series, and will run by our spinal unit, which will discuss a very crucial subject in decision making for spinal surgeons, and will be about sagittal balance. It's my honor to introduce the panel, which is formed of our pioneers of surgery of the spine, Professor Dr. Mohammed Mazid, Professor Dr. Mohammed Wafa, and Professor Dr. Al-Fattah Saud, Vice Dean of Ain Shams University. This webinar is dedicated to the soul of the godfather of all spinal surgeons in Ain Shams and Egypt, Professor Mohammed Al-Ghawabi. I want also to welcome our speakers, Professor Ahmed Badrawi and Professor Ali Masyad. And it is our honor to welcome our international faculty, Professor Jeffrey Wang, Head of Spine Department, University of Thoracic, California, and the former president of Spine and North American Spine Society. And also, it's my pleasure to welcome our great guest speaker, Professor Richard Assaker, Professor of Spine Surgery, Lille University from France. Also, special thanks to Elixir Pharma, who share us all the success. At last, I wish you a fruitful spine night, and I will hand the mic to our moderator today and the maestro of this meeting, Dr. Magdi Youssef, the head of the spinal unit. Tfaddal, Dr. Magdi, please.
Thank you, Dr. Amr. Hello, everybody. Welcome to our fourth orthopedic webinar in Ain Shams University, and we dedicate this first spine webinar to our mentor and the founder of our spine unit, Professor Mohammed Al-Ghawabi, who was a great man, a top surgeon, and exceptional teacher. Let me start by thanking and introducing our international guests to all of you. Professor Jeffrey is a great friend of mine and my teacher also, the head of the spine unit at the University of Southern California, the former president of AO Spine, CSRS, and NES. Professor Richard Assaker from France. They are not only great friends, but they are my teachers. Our speakers from Ain Shams Universities are Professor Badrawi and Dr. Ali Masyad, and our panel, Professor Mohammed Mazid and Professor Mohammed Wafa, and Professor Al-Fattah Saud, the Vice President of the University. He will join us soon. Our program will be divided into two parts. First part is about the understanding of the sagittal balance of the spine in a case-based formatting, followed by interesting talk by Professor Jeffrey discussing the leadership skills. Let us start by the sagittal balance. The sagittal balance had gained great attention since the French spine surgeons had put it into focus. And many parameters, many numbers, many angles had been proposed to be applied in surgeries to solve disability issues, and that is proved to have a close relationship to the sagittal malalignment. I did some sort of a survey before we joined this webinar with my friends and colleagues, and we had many questions about this sagittal. We have to answer these questions as much as we can tonight. Are those parameters really of practical importance? Are they of real help, or they just stay as a prestigious colored drawings on the X-rays in the meetings? Is it correct to put a global standard for the sagittal balance and oblige every surgeon to regain these parameters of his patient to these standards? Nature has its own way in managing things, and life is a kyphosing event. Should we correct this nature event back to adulthood parameters? Since those parameters had gained attention, I started seeing the patients fixed and fused from the pelvis to the dorsal spine. Is it justified? Is it really helpful? Or are we over-treating our patients, changing them into blocks? What about the flexibility and the mobility? And how can I diagnose the compensation failure and the muscle fatigue that justifies any intervention? Are there any regional cultural needs and differences that guides us for these aggressive surgical interventions? I can see, for example, inability to play tennis is an issue in Europe and maybe in USA, but it is not an issue in the Middle East. Complications in osteotomies varies from 10% to 95%, and in many papers, they are really high and risky. Is it justified to do these surgeries to have a win-win situation? And why are we doing osteotomies in bone to correct imbalance secondary to pathology affecting the soft tissues and disc and joints? Why shouldn't we stick to these parts and don't interfere in the bone osteotomies? As spine surgeons, we might think that the kyphosis with aging is only a spine problem, and we jump to correct it, ignoring other interactions with the body systems like the brain, the vestibular system. So are we really realigning the patients in this old age, or maybe we are worsening the cases? Hips and knees are downstairs, and they can be the primary cause of this sagittal imbalance, and we have to take care of this. These are some questions that were raised by many colleagues before this webinar, and I hope that we can answer a lot of these questions in this webinar. We'll start by Professor Richard Asakir. He will give us how to plan the surgery, how to plan according to the sagittal balance put in the background. Professor Richards, please share your screen.
Okay. Good evening, everybody. Thanks, Magdi. Thanks, Professor Harry. It's very nice to be among you and talking about sagittal balance, which is a very controversial topics. And as Magdi said, really realigning patient for a better quality of fusing the thoracic to the sacrum. Is it a good option? So my topics is not discussing the decision making. My topics is once you decide to align your patient, how quick introduction on theory, and then challenge you with an illustrative case that summarize all the basis of realignment. So when it comes to realignment, everybody's thinking about first global balance, a little bit less about regional alignment, and this is very important, and I will insist and focus on this. So it's distribution of lordosis in the different region of the spine is very important, and we have to carefully look to the compensatory mechanism in order to correct them. Now, all this paper from Virginia and Schwab and Frank Schwab about that sagittal vertical axis has to be less than 50 millimeters, lumbar lordosis equal pelvic incidence plus or minus 9 degrees. And if pelvic incidence mismatch lumbar lordosis, mean that you are misaligned. This is very basic because actually you might have a good match between pelvic incidence and lumbar lordosis, but you can have also a misdistribution in lumbar lordosis and get to a bad results. I will come back to this later on. So sagittally, not only it's a matter of global balance, but it's also a matter of segmental distribution, and the segment from L4 to S1 70% has to be between L4 and S1. And also coronally, L4 has to be parallel to S1 in order to control your correction. So if you go to such a revision patient who comes to us for failed back surgery syndrome, he had just a short segment at the lumbosacral area And the problem is obviously this hyperlordosis. This is yet, and this patient is complaining of back pain, that misalignment in the sagittal plane is correct. So let me show you how to think about this case and go to this illustrative case. So first, what's global balance is this plumb line drawn from C. You can see here that the distance between the posterior aspect of S1 to the SVA is larger than, is longer than 50 millimeter. It's about 70 millimeter. The PI of this patient, the pelvic incidence of the patient constant, is about 78 degrees. So what's next? Next would be to measure lumbar lordosis. It's L1, S1, 16 degrees. 2, it's hypolordotic. And remember, it has to be is highly so it's retroversed here, and it has to be 20 millimeter. And L4S1 is 10 degrees. It has to be 70% of 78 degrees. So this is how we correct this patient with osteotomy at L3 here, at L4, and then you can see before and after. So globally, this patient is balanced and his quality of life is improved. What happens if you undercorrect this patient? And this is where the problems comes. If you do an inappropriate fusion on this patient, he will get a more miserable life. So it's better when it comes to arthrodesis, alignment, and alignment has rules, and I will go through illustrative. Deformity correction, of course, we go for global better balance also, but we have to restore local lordosis. This is another example here. You can see before and after. You can see CT scan. You can see the CT scan on the top right with the osteotomy of L4 and the sagittal alignment. And you can see the profile of this patient is, you can see the legs are bent and on the left side, they are straight on the right side. This is mean that compensation is gone and patient had a better economical posture.
Richard, can I ask something in this here?
Yeah.
When you look at the parameters in this case, like the case that you showed in the beginning, what is the role of the pelvic tilt in this condition? What does it indicate?
Yes, I will come to this, Magdi.
Okay.
Mechanism. When pelvic tilt increase, mean that the patient is retroverted. When it so he's trying to compensate to keep his head on the center of gravity. So this is a compensatory mechanism. So the rule of this is if you antivert, if you correct your patient and the pelvis is antiverted, mean that you are getting a better alignment. And you will get your answer, Magdi, through my illustrative case, because I will go back to numbers and equation.
Okay.
So first of all, what is the rationale of pre-op planning? Why should I plan? Why not opening a patient and start planning during surgery? Preoperative planning has to be preoperative because it's correction to is determined. So you have preoperatively know what are the numbers that you need to achieve to get back. So you are defining a surgical scenario. Your surgical steps are defined. I think it's very bad when you start thinking during surgery. You have to think first and do your surgery second. So why planning is important? Planning is, again, defining surgical steps, and for example, the site of osteotomy, the type of osteotomies, to get a better workflow, to get less blood loss, to reduce the length of surgery. And this is very important. If you know before surgery what are you doing during surgery and what you have to do step by step, it will save time. Think first, plan first, and control it surgically. If you look to this patient, she's Parkinson. As you know, it's very fragile. You look at her deformity. There is no question about how bad is her quality of life because of her deformity. We've been discussing with neurologists, and we end up by correcting this patient. This is the correction, T2, S1, S2. So if you start thinking during surgery, you will increase your time, blood loss, etc. So this has been planned before surgery. I knew before surgery that my osteotomy site is at L3, that I will do a double rod, that I place my screws from T2 to S1 and the ilium. All I had all measured, and I'll go back to this. Look, this is a recent case. This is amazing case about spondylo T2, something like that, and he came because of his drop head. He cannot look horizontally. So first, when I looked at this patient, intuitively, I was planning to do osteotomy at C7 or T2 because he's complaining of drop head. And then I start thinking, let's plan the surgery and see how can I correct his alignment. So I have done 3 scenarios. The first one, I have done just Smith-Peterson osteotomy at L5-S1, 4-5, 3-4, 2-3, L1-2, T12-L1, and T11-T12. But before starting my back to normal pelvic tilt, so I decrease his pelvic version and bring it back to something acceptable around 20 degrees. And I have done my osteotomy, and you can see my alignment is correct now. So if I do a Smith-Peterson osteotomy from L5-S1 till T11, T12, I can get good alignment and get back to horizontal gait. Second scenario, I have bring back my pelvic tilt to 22, but I have done an osteotomy at 40 degrees in L4, which is very challenging. 40 degrees in L4, and this bring back my patient to good alignment. And my favorite scenario was the third one. Brought back my pelvic tilt to 20, and then I have done an osteotomy by 22 degrees. Every sign deformity could do an osteotomy with 20 degrees, 22 degrees of correction of lordosis, and have done a Smith-Peterson osteotomy from T11, T12 to L5-S1. And this was my decision to do an osteotomy of 22 at L4 and Smith-Peterson osteotomy at all the levels. And this is what I have done. So this is before, this is after, and I get a better alignment. This is immediate post-op. Patient will get a better alignment in 3 months later on. So this is about planning. How to plan correction? Planning correction could be just a paper, transparent paper that you cut and you correct and you align. And correction. This is ancestral. You can rely also on more softwares and applications.
Richard, sorry, Richard. I think Dr. Richard, audio is not proper. We cannot hear him properly. Richard,
what you saw, yes.
We cannot hear you properly. There is something wrong in the
Yes?
audio. Ahmed, can you
hear
check
me?
this? It is not proper. I think it needs some sort of... Ahmed, can you check for this audio? There is a problem. You cannot hear Dr. Richard properly.
Oh.
Although we hear you properly, Magdi, so there is something wrong with the connection at Richard's side.
There is something in the connection.
Because I'm connected with 4G.
Okay.
Okay.
Can we modify this to
fine.
Wi-Fi or something?
Connection through something. Is this better, Magdi?
Yeah, much better.
Much better.
Much better.
So, so let me go back to here. How to plan correction. You can use. I think everybody knows about those transparent papers that you can draw your spine and cut angles, or you can rely on softwares and application. This is my KOPS. KOPS is a software that you can download your DICOM image in the application, and you get on the left side all your parameters: pelvic incidence, pelvic tilt, sacral slope, and also lumbar lordosis, etc. And you can, with KOPS, you can assess also if your correction, as you can see on the right side, you can see if your parameters are in the green. The green zone is the optimal zone for alignment. But let me go through this, and then you will understand better. This patient has a 63 years old. Are you hearing me well now?
Yeah, better.
Yeah. So now we'll challenge and we'll see step by step. She's complaining of axial pain, walking distance less than 100 meters, neurogenic indication. Or proms are bad. I mean, osmohistory score is high, SF12, SRS22 are confirming that she has a very bad quality of life. This is the patient. You can see in standing position, she's anteriorly flexed, and when she walks, she bends anteriorly more and more. Can you see this?
Yes.
Yeah. So again, this is her full spine, and I would not insist about this. I mean, everybody agrees that to assess a deformity, especially in adult degenerative deformity, a full spine is mandatory. So this is a full spine. This is not the KOPS on the left side in 2012. And you can see there is SVA is more than 120 millimeters from the sacral here. Coronally also we have an offset, and you can obviously see all the compensatory mechanism. On the right side, retroversion of the pelvis, flex of the knees, and also a little of hypokyphosis at the hour. So where to stop now? And this is my test to see if patient is compensating in the thoracic area. If he's unable to extend his thoracic spine, it's useless to do a short fixation from, let's say, T10 to S1. In this situation, if there is no compensation at the thoracic spine, it's mandatory to go till T2. We have done also traction maneuvers here to see the flexibility of the spine, and you can see that there is some flexibility on the lower lumbosacral area, but not at the apex. Now the CT scan, you can easily see that there is some mobile segments, but also there is synostosis, and at the upper lumbar area, it's one block. It's fused. This is the coronal, and this is the sagittal, and this has to be into consideration. It has to be considered in your alignment strategy. And actually also there is a big osteophyte synostosis. So the upper part of the lumbar and especially at the apex is fused, and we have mobile segment at L4-5 and L5-S1. This is a 3D alignment. So I can stop here and ask ask about how do we decide to do the alignment.
Okay, can we go back, Richard, for the original X-ray?
Yes. My first question is, would you agree, maybe Mohammed can answer us, would you agree of going to T2 and not to going to T2 and not to T10? What do you think, Mohammed?
Dr. Mohammed Wafa?
Yes, no, here I would go for T2 actually. T10 is maybe even below the end vertebra of the scoliosis also. Not only regarding the kyphus.
Yes, but also coronal, yeah.
Yes.
But I want to point out that if you don't have a thoracic compensation, which is illustrated by hypokyphosis on your x-rays and by some extension on your clinical tests, if you stop below T2 or on the lower part of the thoracic area, you will have junctional kyphosis.
Junctional kyphosis.
Sure. Okay.
This is a clinical test.
Richard, can you explain the test in details?
Yeah.
What do you do?
You ask your patient to lie prone, and you ask her to lift back her shoulders.
Okay.
If she, as you can see here, if she starts, pushing on without using her hands, of course, and you can see here there's no way to extend her thoracic area.
So she exhausted all the compensatory mechanisms. So you have to do everything.
Yes, and also my second question is: CT scan mandatory? Yes, because this is the only way to see what is expected to be where are the mobile segment versus rigid segment. So I do always almost a full spine CT, full body, full spine CT in order to reconstruct and get my synostosis.
You mean if you find disc levels, you use the disc levels for interbody fusion and correction?
Yeah, if you can see in L4-5 here, you can see there is a vacuum. Have you seen this?
Yeah.
That means you calculate the mobility of the disc or the facet joint also in the CT scan.
When I see vacuum, I expect. Wow, I don't know why my. I'm back. It's back.
Okay.
Can you see my screen?
Not yet.
No.
Ahmed, is there something to be done? Ahmed.
Wait, I'm back.
Okay.
Can you see it now?
No, we still see you, which is very joyful. But we're waiting for the screen.
Okay. Where is Zoom now? What happens?
Well,
I think the admin of the meeting can just share the screen of Richard on our screens. He can do that.
Mustafa.
I'm going to get connection again.
He disconnected and he tries to reconnect.
Can you see this?
Okay, yes.
My God.
It's just
Okay.
put it on presentation mode so we can see it better.
You can see it?
Yes, yes. Yeah, I just start the presentation mode.
Yeah. So we do also a traction to see the mobility. And again, if you look here on L45, there is a vacuum. And you know,
Richard,
no.
Just get to the presentation mode and go back to the slide because it came back from
you are in the first slide now.
But I was on the presentation mode.
It started all over again.
Here, you can see my presentation.
Yes.
Yeah?
You see that. We just see the slides, and it's on the first slide.
Yeah, but I don't know why it's not running. I mean, it runs on my. I will stop it here, get it back. Here we are. Here we are. And now, first slide?
First slide.
Yes.
Oh, I don't know. I have a problem here.
I think we need the admin, Magdi, to interfere and try to do it from our side.
Yeah. Ahmed and Mustafa, where are you?
I'm quitting and back.
مجدي بيتهيألي الادمن لازم يقدر هو يتدخل.
هو ما عندوش بس برزنتيشن يا دكتور عبد الفتاح، اصل هو ما عندوش الادمن، ما عندوش.
لا بس هو يقدر يخش على السكرينز بتاعتنا كلنا ويقدر يعمل كده. يفورس ان واحد يبان فول سكرين مود و يخليه يشير البرزنتيشن معانا. الادمن يقدر يعمل كده. ما اعرفش بقى هم، انا مش سامعهم اصلا انترفيرنج معانا، يبدو ان هم خرجوا بره الميتنج اساسا يعني.
اوكي.
Is it first slide?
Yeah, no, it works.
Yeah, it's working now. You can go to the case now, and we continue the discussion.
Okay, so you can.
Okay, so you said that she is not compensated, and Dr. Muhammad Wafa's opinion is that you have to go up.
Yeah. So okay. The CT scan is done. This is a 3D reconstruction. MRI is also important, especially if for some reason you want to stop at L5 to see the quality in L5. So here is the key of this. Again, I brought my DICOM to the CAIOPS, and you can see here at the pelvic tilt here, you can see that there is a strong retroversion on the right side. It's away in the retroversion from the green zone. So this gives you the pelvic tilt is 35. It has to be less than 20. Okay. Pelvic incidence is 58, so pelvic tilt has to be around 15. So let me show you the simulation now. If you look here, this is a simulation. I brought pelvic tilt to the green zone, you see? Okay. So patient is falling down because this is a compensatory mechanism. This is simulation. Then I start my osteotomies. In L45, I went for Smith-Peterson, 10 degrees. And then I distribute my osteotomies virtually on all the segment, L12, T12, etc., etc. So all the Smith-Peterson osteotomy, and we know that Smith-Peterson osteotomy gives you less than 10 degrees. So in between 7 to 10 degrees. So and you can see that the spine is getting more and more straight, but it's not enough. So now I went for more aggressive osteotomies at L3, and I assume that I can get something like 25 degrees at L3, and this is a final result. So this is my simulation. Smith-Peterson, excuse me?
This you did the PSO at L3.
At L3, and PSO gives you 25 degrees. Smith-Peterson gives you. Yeah.
Richard, can I ask a question, please?
Yes, please.
Yes.
Yes, ma'am.
Your type of osteotomy is not depending only on the degrees of correction you need, but also on the mobility of the anterior column. Because for Smith-Peterson, you need an anterior column which is mobile.
Yes, this
so
is.
Can you highlight this, please?
This is why I just put 5 degrees and on the upper part. Yeah, if Smith-Peterson, you have to have a mobile disc. We know that.
But what is the Bonti osteotomy? You mean Bonti because there is similarity between the Bonti osteotomy and the Smith-Peterson. It is a little bit confused. So you mean Bonti osteotomy, little osteotomy at different levels can make correction. Then the pelvic pedicular subtraction osteotomy at L43. This is combination.
Yeah.
Is that
Ponte
you mean?
Yes, yes. Ponte it's combination. Yes, exactly. Yes. Ponte is taking the inferior facet at each level. Smith-Peterson is taking the inferior and the superior. It's called interpedicular osteotomy.
Okay.
But what Masoud says is very important. You cannot pretend doing Smith-Peterson in a non-mobile segment.
Yes.
That's correct. So this is my patient here before, after, before and after. Yes?
Richard, can I just add something here to delete this confusion between Ponte osteotomy and Smith-Peterson osteotomy? We can put it as link. He said it's a first degree osteotomy or something like that. When you remove only parts of the posterior column and having a mobile anterior segment without removing anything from the body or the disc space. So this is much easier than, at least in our part of the world, than referring to Ponte and Smith-Peterson, which is very confusing.
Yeah, they call it PCO.
Yes.
Both of them. Yeah.
Yes, playing only with the posterior segment and not interfering with the body or the disc space.
Yes.
It's shortening the posterior column on the facets, but you have to have a mobile disc.
Okay.
Perfect.
Yes.
So
excellent correction, this one. Very nice.
And when I showed this to seniors, colleagues, the question is, how do you control this intraoperatively? So let me show you some nuances. Either you have a format, and you can do in your operating rooms your long format coronal AP view. On sagittal view, as you can see on the left side, you can measure on your C-arm. And on the left side, you have to have a big format. What we do routinely in our place is doing with the 3D fluoroscope, we have an O-arm, we do multi AP views and we stitch them. So you can see here the first step here before surgery, then correction, and you can see that the coronal correction is not ideal, and then we play with compression distraction in order. So you can assess coronally, which is more difficult than assessing sagittally. This is another example here also before and after surgery, and during surgery, for correction, after correction, you see the 3D fluoroscope on the top here with 2D and 3D, and below this after the osteotomy, corner osteotomy, and get the correction. So it's not that difficult to assess your correction during surgery. And this is the result. A year after, you can see the patient before surgery, and this answers Magdi about the benefit of doing such an aggressive surgery, and the key for this, if you want to have a good result, you have to have from the first shot a good balance.
Excellent result, yeah.
Yeah. Let's see. Yeah.
Can we take take care of the time, Richard? We can see another case.
I stop here. So I can answer a few questions. I'm sorry for this connection.
No, it's very nice.
Actually, I'm in vacation, and my place here is I'm discovering internet. This is why we got this problem. I'm sorry.
Okay, can we have like the take-home message for the planning before we go to the cervical cases?
Yeah, my conclusion is global balance is not the only parameters you have to look at. You have also to look to the alignment between in the lumbar area, and mainly between L4 and S1. Make a full assessment to get your synostosis, to assess the rigid versus flexible, and look carefully to the compensation compensatory mechanism. And then plan and simulate before surgery in order to save time and blood, and decide what type of osteotomies you have to do. This might take home message.
And do you always use this KIOP software? It looks very, very, very good. Excellent.
What I showed you is a 2D simulation. Now they get a new application with 3D simulation. It's nice. Yes, it's good.
Okay.
But there is many others also, and it's not the only one in the market.
I noticed that you divided the lordosis into upper part and lower part. Does it help you in the decision making in choosing the level of the osteotomy? You have chosen L3 in this case.
Yeah, I choose L3. Usually, we have to go as low as possible, because lower you are, better your correction is for the same angle, as you know.
Okay.
Of correction. But sometimes if you have doubt about the quality of your pelvic fixation, it's better to be at L3. Okay. I would like to add a comment on the Egyptian, I would say, Spine Society. I have a fellow, he was a fellow of Masoud and Magdi and Professor Wafa. He's Samer Musa, you know him.
Yeah, Sam.
So he's helping me in all this stuff, and he's great. I enjoy talking about not only spine with him. So I think he's spending one more year with me, and I hope that going back to Egypt will help you there in getting good experience there. And thank you guys for sending this guy to me.
Thank you very much, Richard.
Richard, yes. we are proud of that, and we promise you before Samer comes back, we will send you another very good guy.
Thank you, Abdel Fattah.
Okay, thank you, Richard.
Okay. Thank you.
Now Thank you very much. Now Dr. Jeffrey Wang, he will show us some cases about the cervical part of the imbalance. Dr. Jeff, can you please share your screen?
It says that I can't share while the other.
Richard, can you?
Yes.
Yes. Okay. Thank you.
Okay. Can you see my screen?
Yes.
Okay. Well, first of all, thank you for inviting me. And Richard, fantastic talk. A lot of the principles that Richard spoke about are right on the money, and I think there was so many valuable tips that I got from his lecture. I'll try not to be redundant, and I will not try to repeat anything, but I want to talk about how I assess cervical alignment. It's an honor for me to participate, and I want to thank you, Magni, and all the organizing committee for inviting me to speak. So I'm going to talk about how I assess cervical deformity, and I'm going to start off with a case. This patient came to me years after this, so I don't have all the early x-rays, but these are the radiographs that I could find. In 2007, this was her x-ray, and so she had a previous lumbar decompression fusion. And I know that she also had a cervical decompression fusion. And this was her alignment in 2008. And what we can sort of see is that she has reasonable lumbar lordosis, but her overall balance from a plumb line dropped at C7. She was much posterior to the pelvis. And this is what we typically see for patients that have a primary cervical problem, and they're trying to compensate with their thoracic and lumbar spine. Because the problem is really more located typically in the cervical spine. Now, she had a very bad regional balance in the cervical spine, and then she had a lumbar surgery where they extended her fusion. I do not know if she had adjacent segment problems, but they did extend the lumbar fusion up a few levels, and they tried to recreate the lordosis. But you can see she's retrolisthesing down here, and she just cannot compensate anymore, and her head fell forward, and now she has a chin on chest deformity. And so her overall plumb line from C7 is in reasonable balance, but obviously her local regional balance in the cervical spine is very poor. She's looking straight down. And so we had to do an osteotomy. I believe we did it at C7 or T1. And we got her alignment better. She can now look forward. But this is a great case to illustrate, to understand where the deformity is located. Is it a primary cervical, or is it a problem with the thoracic or lumbar spine? And so what I'd like to talk about for a few minutes is how I approach cervical alignment. And then I'll show how I do a cervical osteotomy. And I'll try to stay with my 15 minutes. So the first thing I do is I look at the regional balance just in the cervical spine. And I think we all have different measurements. At the Cervical Spine Research Society, there's a million different measurements. And every time I go to that meeting, someone presents a new measurement. And I'm just as guilty of that, because we have published dynamic MRI papers with all the different measurements. But I think the most important thing is I want to get an assessment of the C2, C7 regional balance, and whether or not the patient is fallen forward or whether they're in good alignment. And we know that normally they're within 1.5 centimeters. And then once they get beyond 4 centimeters, they start to have problems. Not only do we know that they do not do as well, just like if we're off balance, as Richard mentioned, in the thoracic and lumbar spine, but we also know that and we've done MRI studies looking at the muscles atrophy. You get fatty infiltration of the paraspinal muscles in the cervical spine. And so there are a lot of problems that occur when these patients are off balance, not just that they have bad alignment. And we also know that it's important to assess them before surgery. It's also important to assess them after surgery so that we can end up post-operatively with an alignment that looks like this, rather than having a poor alignment after surgery. And we know that they will not do as well if they're ending up with a poor regional balance. And we know when we look at laminoplasty, their myelopathy won't do as well. If we look at spondylolisthesis, and we've published a lot on having a high T1 slope and being off balance, you have more spondylolisthesis and perhaps more adjacent segment disease. And we also know we'll have probably more adjacent segment disease if we don't put them back into balance. And so when I assess the regional balance, I want to get an idea of how far they are off. The second thing I do is I look at the global alignment. As Richard mentioned, we have to look at the entire spine and understand how the thoracic and lumbar spine relates to the cervical spine. Is it a problem such as this, where as I showed you a case before, this is a primary cervical deformity and the patient is compensating with their thoracic and lumbar spine? Or is it a primary thoracic and lumbar problem and you're seeing compensatory lordosis in the cervical spine? But it's important, as that case I showed you to start off the lecture, it's important to understand where the problem is, where the primary deformity is. This is an example of a primary cervical deformity. This is a patient that has a pelvic incidence of 50, the lumbar lordosis is 72, and so they have a very good lumbar lordosis. But again, if you look at the C7 plumb line, you can see that again, they're much posterior to the pelvis. And so they're compensating for a primary cervical deformity with their thoracic and lumbar spine. And you can see by correcting the cervical problem and bringing the regional balance more into normal alignment in the cervical spine, you sort of lose that compensation in the thoracic and lumbar spine. So here the problem is in the cervical spine. This is another case. This is a patient that had a primary cervical deformity after a laminoplasty. And again, if you look at the C7 plumb line, they're posterior to the pelvis, which is what we typically see when we have a primary cervical deformity. But again, you have to look at the thoracic and lumbar spine to make sure that it's just not something that's compensating. The next thing I do is I look at the location of the deformity. And if you look at the ISSG, they've talked about understanding where the deformity is, whether it's in the cervical spine, in the thoracic and or the cervical thoracic junction, and taking into account some of the modifiers. But you know, the important thing to understand is, for example, this on the far left here, this patient has good global balance between C2 and C7. They just have a focal kyphosis. Whereas this patient here has a good lordosis actually in the cervical spine, but they're globally imbalanced, probably because more of a problem in the thoracic spine, or at least at the cervical thoracic junction. So again, trying to understand where the deformity lies. The other thing is that we know in the lumbar spine, most of the lordosis is L4 to S1. We know that most of the lordosis in the cervical spine, 75 to 80% is C1, C2. And we don't really have much normal lordosis in the lower cervical spine. And this is an area that we can try to make up for some loss of lordosis. But you just have to be very careful. And this is what I teach our fellows. You know, if you're doing a C1, C2 fusion, a lot of times you extend or flex the neck a little bit to get the occiput out of the way so that you can actually access C1. And the occiput, if they have a little bit of cranial settling, sometimes that blocks your view. The problem is that if you don't restore that lordosis in a C1, C2, then you can actually make up for it and cause problems in putting more of the compensatory mechanism in the lower cervical spine. The other problem is that you're normally a little bit kyphotic or neutral at occiput to C1, and some people try to put too much lordosis for occiput to C2, and then you see a compensatory kyphosis potentially in the lower cervical spine. The thing I also look for is flexibility, and I think people are always talking about in the thoracic and lumbar spine, but in the cervical spine, we want to understand if the deformity is also very flexible. This is a case of a patient that had a post-laminectomy kyphosis. So they had a previous cervical laminectomy, and now they have a chin-on-chest deformity. Looking at their full-length films, again, you can see that the C7 plumb line is posterior to the pelvis. So this is typical of that of a primary cervical deformity. And they have a little bit of rotation and maybe some coronal imbalance in the cervical spine. So the problem here is in the cervical spine. And then when I get a CAT scan, which I find very, very valuable, what I see is that the upper cervical facets are probably fused, but the lower facets are probably not fused. And so these are probably mobile, and this is at least probably a flexible deformity from C4 down to the lower cervical spine. And this patient has bad myelopathy. You can see that the spinal cord is being quite compressed here on the axial views, and there's a lot of compression of the spinal cord because of the kyphotic deformity. And so this patient, we brought and we put him in traction, and we were able to correct a lot of the kyphosis and even some of the rotational coronal problems just by putting them into traction. And you can see here that the patient has a nice straight neck here in the coronal plane, and you can see that it may be fused up here, but at least we've gotten rid of a lot of the kyphosis here in the cervical spine. And I was planning on doing this front and back, especially because this patient had a vertebral foramen that would not allow me to get very long screws into the C2 vertebral body. But our bone quality is actually very good, and I was able to do this all from the back without having to go in the front. The other thing is, under flexibility, I always look at specific areas of stiffness, and I'll go back to this case. You know, I knew that this patient was relatively fused up in the upper cervical spine, and so I would not get too much correction there. It's important for our residents and fellows to understand this, because you can put this patient into a lot of traction, but because this is fused, you're not going to get you're not going to get any correction through here, probably because they're already fused. And so you need to stop the traction once you've corrected as much as you can within the flexible part of the curve. The other issue is whether you do an anterior approach, and sometimes you can't do an anterior approach because the chin is on the chest. Certainly, sometimes it's flexible enough where you can put them into traction and gain some correction, and that may allow you to do an anterior approach. And so this patient here on the left had a chin on chest deformity. They're relatively stable and autofused here in the lower cervical spine, but here the facets were open. I felt there was mobility here. And so with traction, I couldn't correct the bottom part that was fused, but I was able to kind of correct this part here, and that allowed me to do an anterior approach. And then we were able to do a corpectomy, get some correction of the alignment, and then go in posteriorly, and we wouldn't have to do as much of a work from the posterior part. And we're seeing a lot of this in the thoracic and lumbar spine with the hyperlordotic cages in the lumbar spine. Instead of doing PSOs, a lot of times you can do anterior and posterior approaches using hyperlordotic cages and getting a lot of the deformity correction with helping with the anterior approach. The other thing that when you do an anterior approach, you need to do a good release of the uncovertebral joints. And then I like to put vertebral spreaders in there, and you can actually gain a lot of correction going in from the front. So even if you put them in traction and get some access to the anterior cervical spine, it's very powerful to try and correct these from the anterior part. I like to use the paddle spreaders that we use with our artificial discs, and those are parallel distractors, but they have a wide sort of plate that allows you to go in there and actually distribute the force. And I don't like to use the Caspar distractors because those can cut through, but you can actually get quite a bit of distraction anteriorly and get a lot of correction. You just have to be careful because you might be closing down the foramen in the back. And Dan Rue has talked a lot about doing anterior cervical osteotomies. In fact, he tries to do all of his osteotomies from the front. And one of the tricks is that as you're doing the reduction, you can actually push on their forehead. And even if they have fused facets, a lot of times if you just push gently on the forehead, you can actually get them to break through the facets, and they'll break through right at the facet joint, which gives you kind of a safe and controlled osteotomy from the front. And the last thing is about biomechanics. You know, this is a case where this patient had just a local deformity, had myelopathy, but this patient has very poor quality bone. And when I saw this patient postoperatively, I commented, I mean, the regional balance is poor. This is relatively stiff in the lower cervical spine, and there's very few screws here in the small lateral masses. So this was actually pretty much doomed to fail, and you can see this pulled out. And so in this patient, I probably would have gone up to C2 to get bigger screws. And sometimes I'll do front backs just to put in segmental grafts, put in an anterior cervical plate, and that at least gives me more stability, which can protect the posterior constructs. And this is the case I showed you earlier. And we got good correction here But if I was worried about the fixation, certainly going in the front, even after you've gotten your correction in the back, you could still go in the front and do segmental grafting. You can put your cervical plate on there and you can reduce the spine to the plate. And you can also, it will help protect the screws in the posterior part. In this patient, the bone quality was actually very good. And as we saw in the preoperative CT scan, this was actually auto-fused up here. So it wasn't just the C2 screws, but it was all 4 screws here in the superior construct. And, you know, she's done very well. So, but I would have a very low threshold of going into the front and giving us extra supporting. Now, as far as the surgery, I think we all know that these have a pretty high risk of potential complications. And so I always talk to the patients about up to a 40% complication rate. That can seem rather high, but it can entail both minor and major complications. I tell them they may have swallowing issues. They may need a gastric tube, and that there's no guarantee that they will be able to swallow. I tell them they'll be in the ICU. They may have a prolonged intubation, and I try to pre-op them. We use spinal cord monitoring and we optimize their bone preoperatively. There are a lot of different techniques to use, and just like Richard talked about, the different types of osteotomies you can do in the thoracic and lumbar spine. These are the 7 types of osteotomies that you can do in the cervical spine. I think if you can get segmental correction. I will do multi-level anterior surgeries, but the main workhorse is sort of a posterior cervical osteotomy. The key to doing these surgeries is to have a team. And so the team is completely aware and that there's really good communication with all the team members. This is a case where we are doing, I believe, a C7 osteotomy, or perhaps it's a T1 osteotomy. You can see that we've gotten to the point where we're ready to basically do the osteotomy. We exposed the spinal cord. Here's a video of us being prepared, where you can see the nerve roots that are free here. Their nerve roots are free up here. We're taking out any of the bone that could potentially pinch the spinal cord as we do the reduction. We're making sure we feel around the anterior part of the cord. Here, we're breaking the posterior cortex, which is kind of the last step that we do. We've already taken down the lateral cortex. We've already pretty much decancelated the body. Here, we're ready to do the correction. And before we do the correction, we put 2 rods. Here, we're taking down the posterior cortex. You can see with that instrument. We're feeling around to make sure that there are no bony fragments that will impinge on the spinal cord. And then on the right side, we are putting in 2 rods, temporary fixation rods, and basically getting ready to control the neck. Now, I'll usually stay within the surgical field, and I'll make sure that I have great communication. I usually have one of my partners with me. The key step here is that when we're ready to do it, we make sure the patient's ready, the volume is not hypovolemic. We let anesthesia know. We let the spinal cord monitoring person know that we're about to do the correction. We line up the screws so that when we bring the head up, the neck will go along the line, the plane of the rods, and we'll have 2 rods in place. Now, this is one of my partners here. They've preoperatively known how to unlock the Mayfield. And then I'll control the head. So I'm holding the head in position, and I won't let go of the head until they've unlocked the head and they say that they have good control of the head. And then once my partner who's down here holding the head, I'm holding the head, and now he's got the head, I will unloosen the nuts, which will allow the bottom part of the rod to be free. And then here you can see we're bringing the head up together as a team. And here we're correcting here we're doing the osteotomy. Here we're bringing the spine. And again, it's going to fall right along the plane of the rods. And here now he's got the head, he's locked the head. So I don't let go of the head until he tells me that he's got control. And then I tighten this. We've only corrected it maybe halfway at this point. We may stop, make sure anesthesia is okay. We will run another spinal cord motor just to make sure the spinal cord is doing okay. maybe let the spine adjust to the new space and just let it sit here for a while. We'll continue to check to make sure there's no bone that's pushing into the spinal cord, and make sure it's still free, and that some of the bony edges of our osteotomy, make sure there's been no subluxation. And now we're going back to grab the head, and my partner is going to unlock the head again, and we'll finish the correction. And so now we've unlocked the rods again. Here we're bringing the head back to finish the correction. And once we feel like we've got the correction, we'll lock it into position. We want to be very careful that there's not too much buckling of the spinal cord here. And again, we want to feel around the spinal cord to make sure that there are no bony fragments there. Here, I think we've completed the correction. I think there's a little bit more buckling here than there is here. And so we've brought the spine back. I'll fast forward through this a little bit. And I think that's the final position of the correction. And so once we have the final position and the head is locked, I'll let go of the head. I'll tighten up the rods. We will, again, feel around the spinal cord, make sure there's not too much buckling of the spinal cord. We will run another spinal cord motor potential to make sure everything is okay. And here's where, if there was any coronal deformity, you could have done a little bit more of a osteotomy on one side, and then you could have tilted the head to try and correct some of the tilt if you need to. And I think this is the final position there. And this is the final X-ray this is, I think, an ankylosing spondylitis case. This is how I do it now. There are many devices, but we call this the rack. I think there are many companies that make devices like this, but these are locked into the screws. I think we're doing maybe a T1 or a T2 osteotomy here, and we're just putting in maybe a small piece of bone, like a T-lift cage, so that we don't shorten the spine too much. The nice thing about this device is that it allows, the rod is not in the way, so we can still look around the spinal cord. This is connected bilaterally, and it has these connectors that allow us to dial in the amount of correction that we want to do. And I always try to use a pedicle screw at C7 and T1. If we're doing a T2 osteotomy, then having a pedicle screw at the top part makes you feel much better, because the pedicle screw is going to be stronger. If you do it at T1, try to put a pedicle screw in at C7, then you don't feel as bad with this device on that pedicle screw, because you know it's a little bit stronger. And this is how we do the correction now. Again, you can see the spinal cord's all exposed. You can see we're just dialing this in. You can stop right there. You can run a spinal cord monitor. And you can actually grab this thing. If it starts to subluxate, you can grab it and you can tilt and push on one side as you're starting to close the osteotomy. If you start to get some changes, you can open it back up again. You can also close down one side more than the other if you're trying to do sort of an asymmetric osteotomy. Here's a situation where you can do it all by yourself. Again, this is, you unlock the head, you still have good communication with your team, but again, you can dial this in, you can do it very slowly. You, again, can run spinal cord monitoring. You can stop halfway and let the spinal cord relax, and then you can complete the final osteotomy later. But I think it's a much safer way of doing it. It's a much more elegant way of doing it. Again, we've stopped halfway. We're checking around the nerves to make sure everything still looks okay. We've run a spinal cord monitor, and now we're finishing it, taking the osteotomy the rest of the way and closing it down. And so this is the final X-ray. I believe it was up in the upper thoracic spine, and here you can see the alignment is a little bit better. This patient has ankylosing spondylitis. The last thing is I do use navigation. I think it helps me. This is a case that has a pretty severe deformity in the cervical thoracic junction. When we has bad regional balance, and you can see there's almost a right angle here on the MRI. So this is a pretty severe curvature. And so we did a VCR at T1. We used spinal cord monitoring, and we resected everything. And the navigation allows me to make sure I've gone to the anterior part, I've resected everything, there's nothing holding us up. In this case in particular, this wouldn't move. this deformity has been there for so long, the soft tissues were so contracted, even though we were comfortable that we had resected all the bone, even to the anterior column, showing us with the navigation that we had resected enough bone, the spine still would not move. So in this situation, we actually closed the patient up. We brought them to the unit and we reduced them under halo traction. And then we brought them in and fixed them into position. And you can see the final result looks very good. So we've corrected their poor sagittal balance in the cervical spine. So with that, my take-home messages are consider all the spinal parameters when you're considering a cervical surgery. Again, preoperative planning, as Richard had mentioned, make sure you understand and figure out exactly what you want to do. And I think that you need to have a team approach to minimize complications. I usually do this with one of my partners. We plan out the steps. I trust my partner to go underneath and unlock the Mayfield to help control the head. And then I always talk to the patient. I think the best way to manage a complication is to talk to the patient before surgery and let them know that it can happen and it can be a serious complication. And thankfully, the ones I've had with patients have been very understanding, and they sit there and say, you know, you told me about it, so I was prepared for it. I think that's the best way to manage it. With that, I want to thank you very much for having me. It's been a pleasure speaking to you.
Okay, thank you, Jeffrey. It's difficult, very difficult cases that you have shown. The first case you have shown, Jeff, where the patient fell, the head fell after the lumbar surgery. Does it mean that it was taken, the compensation mechanism was taken from this patient by the wrong surgery? It's very, very, very dangerous, these cases. If I want you to summarize to us, how can you, in key points, 1 or 2 points, how to make sure that the cervical spine is the main issue, the main pathology, not the lumbar spine, like in the first case? Sure.
So I think it's important. The first thing I think is to look at the global balance, because you want to understand whether the cervical spine is so people have looked at cervical lordosis and it gets worse with age. So you get more lordosis with age, and that's because you're getting more kyphotic in the thoracic and lumbar spine. So you have to compensate with cervical lordosis. And so usually the patients that are compensating from a thoracic and lumbar problem, they have good cervical lordosis. They have, and the T1 slope is more vertical. And that tells you it's probably something. So if it's more than like 35 degrees with the T1 slope, you probably want to look at the thoracic and lumbar spine. But the other thing is that it's not all the cases, but when they can compensate with the thoracic and lumbar spine, their C7 plumb line will be much posterior to the pelvis. And so they're using their thoracic and lumbar spine to compensate for the problem in the cervical spine. But I think the last thing is that, you know, if you, there are many companies that make those, the software that Richard was showing that he uses. I think that's a very valuable tool. And so that gives you an idea with the new technology on dialing in the amount of correction and seeing how the spine is affected. Okay. Any other comments from the panel, from the speakers? I can see in the Professor Sharqawi is with us, Professor Abdouanis, Dr. Mishtawi, and Dr. Hussein Gafi. Gafi is here from USA. Dr. Imad Hashim from Dubai. We are all welcomed. Any comments from the panel, Dr. Richard?
Magdi, can I ask a question?
Yes, please.
Jeffrey, in case of ankylosing spondyloarthritis, you might, I saw that you've done your osteotomy in T2, yes?
Yes.
Yeah. So how is how it behaves the upper thoracic vertebra, because we know there are, even if you do a nice osteotomy, what is your tricks to release the superior part of the thoracic, because it's so ankylosed? How do you,
Richard, still you have a problem?
Do you cut the ribs also, and
Yeah, so Richard, great question. Your internet is cutting in and out, so I didn't quite hear the entire question, but I think you're talking about in certain cases ankylosing.
Didn't hear mine. I mean,
yeah.
You do your osteotomy at T2, yes?
Yes.
But how do you manage to release the upper part of your thoracic spine? Because in ankylosing spondylitis, ribs also, what are your tricks about this?
Yeah, so I do exactly, great question. I do cut the ribs. I do detach it because that's going to block the osteotomy. The other thing that has happened, you know, I trained with Henry Bowman, and he would just basically do the old-fashioned osteotomies where he would just break the spine and he would gap open in the front.
Yeah.
And I can tell you that I've had that happen, even when I'm doing a PSO. And you know, a lot of people say, well, how much correction do you get? Well, I can get a lot of correction, but when I look at post-operatively, and if you look at my first case, it actually gapped open in the front. And so I will actually, I do a PSO because I feel like I'm shortening the spine. But if you try to get too much correction, it will actually gap open in the front, which I think as long as you're shortening the spine, it's probably okay. And I certainly did a lot of osteotomies with the late Dr. Bowman, where he would just break the spine and he would elongate the front. And so I feel like you can pretty much dial in as much as you want. I do it very, very slowly. So I don't, you know, in the old days, at least the people I train, they like to hear that crack. I don't like to hear that crack. I like to do it as slow as possible, but I will fracture it. And if I try to get too much, it will gap open in the front, but I can get a pretty good correction in those patients. Yeah.
Okay, thank you, Jeffrey.
Sure.
Dr. Shakawi is asking you, Richard.
Wang, can I ask a question, please?
Yes, yes, sure, Dr. Fattah.
Dr. Wang, thank you for the great presentation. We have a common friend, Dr. Benzel. I teach with them in Cleveland Clinic spine course for years, so we have a common friend. Actually, I've seen in one of your cases that you're depending on anterior corpectomy for 2 or 3 levels using expanding cage without adding anything posterior. You feel safe doing that with this kind of deformity correction without fear of subsidence? And what are your conditions for using this as a standalone without adding anything posterior?
Yeah, and I actually did do that posterior only. And so I apologize, I didn't show all the x-rays. What I was trying to show is that there are some situations where I have to do it front and back, and they're very stiff in the front, but there are some segments that I think are flexible. And I like to take advantage of that. If I put them in traction, I can correct enough where I can actually get their chin up a little bit, and then I can go in the front and I can get some corrections. If you looked carefully, and I only showed it for a split second, in that particular case, the whole vertebral body was subluxated back against the spinal cord. So I had to do a corpectomy. But typically I can get more correction if I do multiple level discectomies. I distract them, release out, I protect the vertebral artery, but I go out laterally and release all the uncovertebral joints. I over distract them. And then I put a cervical plate on that I bend, and then I reduce the vertebral bodies that are mobile up to the plate, which can give me some lordosis. But in that case, I actually did do front and back. I don't think there's a role for doing just corpectomies alone, unless it's a very minor deformity.
Professor Rafa, any?
Yes, it's just
Thank you,
it's
sir.
nice to see and hear you, Professor Wang. The problem I sometimes face with ankylosing spondylitis and the fixation either with osteotomies or in fractures is that the screws, the lateral mass screws are not holding very well, and the anterior screws are not holding very well. Any tips?
So that's why if you do it at T2, you know, and you bring the O-arm in, you can get pedicle screws at T1, even at C7, and you can get just better fixation. If you're doing like a C7, then you've got these lateral mass screws, and sometimes the bone is not so great, and then you may have to go up to C2 just to get a good screw up high. But I agree with you. Sometimes the bone is just really bad.
and you don't have a solution. I mean, we have to just go with something external then at the end of the operation. Because I had this patient coming in with a fractured cervical spine, an oblique shape of a fracture shape, and I had to do fixation down to C7, and then it's not holding well, pedicle screw C7, and then I had to go to T2, and I'm not very happy at the end of the day. So I went anteriorly and put a graft or a little cage actually, because of the compression of the bodies and a plate, and I'm not very happy at the end of this.
Yeah. So one trick that I sometimes use, you know, I trained with the late Henry Bowman, and we learned to do what's called the Bowman triple wire. And so sometimes I'll have pedicle screws in, I'll have lateral mass screws in, I'll have 2 good rods, and I'll still have spinous processes, and I'll put wires through all the spinous processes, and I'll take a fibular graft, cut it in half, and that fibular strut is pretty strong. And I'll actually drill holes into that fibula and lay it as long as I can across the segment and just put those wires through it and just wire that down. In some tumor cases where maybe a lot of masses are gone, but you have the spinous processes that are still there, I still find that's a nice trick to kind of add to my fixation. And I still do that when I do like occipital cervical or C1, C2, even though I'm doing pedicle screws at C2 and lateral masses at C1, I will still wire in structural allograft there because I think it gives me better fixation, and it's a piece of graft. So especially at the occipital cervical junction, I like to have a piece of graft that touches the occiput down to the cervical spine.
Right, thank you.
Yeah.
Thank you very much, Jeff. Now, Professor Badrawi can you start, but there is only one question from Dr. Sharqawi to Richard. Richard. Hello.
Yes, I'm there.
Dr. Sharqawi is asking you, why did you choose in this case to do the osteotomy at L3 and you did not go for L4 for a better correction?
Because I was doubtful about my caudal fixation so if my fixation at L5, S1, S2 ilium is good enough, I will go to L4. Otherwise, I go to L3 to get more screws below my osteotomy.
Okay.
Right.
Thank you very much. Professor Badrawi will speak about the thoracolumbar part of the imbalance. Professor Badrawi.
Thank you, Dr. Magdi. Good evening, everybody. I'm happy to be among you. And actually, my first experience about the sagittal balance was when I was reading a book about the Aikido art. Aikido art is by Yoshiba. He was talking about that the good stance and posture is reflecting a proper state of mind. And really, I wondered how it is reflecting the state of mind till I started to study the sagittal balance and the body posture. And as we all know that it's very important for saving the body oxygen and the energy expenditure. I actually would like to start from the beginning by an easy case so that we can talk easily about the principles of correcting the sagittal balance. As we all can see here, this is a rounded kyphosis secondary to Sherman disease. There are flexible disc spaces in a 22-year-old female patient, and she's just complaining when she was presented to me from neck pain and low back pain. Actually, she wasn't concerned at all about the how she looks or the body posture at all. And this actually should direct us to think about when we have loss of the sagittal or profile balance, that we should think that there is a compensatory mechanism for the whole body to compensate the posture that is on the expense of other regions like the cervical, the lumbar, and the pelvis, as well as all over the joints of the body. As we can see here, the vertical sagittal axis of that patient, she's markedly off-balanced negatively, and the regional kyphotic angle is almost like 95 degrees. And in terms of this, if we look to the parameters of the cervical profile, we will find that, of course, the lumbar lordosis, the cervical lordosis will be affected, the C2 slope and the T1 slope, which I believe one of the most important parameters for the sagittal balance. T1 slope is reflecting the position of the head or the skull. So even if you cannot get a long film like this, if you measure the T1 slope, you can understand whether the patient is globally balanced or not. Also, the lumbar parameters will be involved, including the pelvic incidence, the pelvic tilt, the sacral angle slope, and the lumbar lordosis. And if we started to measure the lumbar lordosis, here is 70 degrees, and the pelvic incidence is markedly reduced. The pelvic parameters are disturbed, the sacral slope as well. And if we measured the angle from T5 to T12, it will be almost 85 degrees. And the thoracolumbar junction is almost 45 degrees. Actually, the thoracolumbar junction and the thoracolumbar kyphosis is very important to plan the correction. And it is very important to be corrected very well in addition to the deformity of the thoracic spine or the thoracic region, because it can end when you correct the kyphosis locally or at the thoracic region without being concerned with the thoracolumbar junction for a flat back or off-balanced posture. So even when we contour the rods for placement at the end of the surgery, we should consider contouring them properly to correct or to re-establish the thoracolumbar junction angle. Taking in mind,
yeah. Can we open the discussion for this case before you will go on?
Yes, sure.
Yeah. May I ask Dr. Richard, what do you think, Dr. Richard, for this case? What do you do? Richard. Hello.
So
somebody's calling me?
Yeah, we want your opinion in this case.
Everything has been summarized. So the compensation, the compensatory mechanism, etc. So my main, the main problem here is the thoracic kyphosis. I would try to do another X-ray with a pillow below the apex of the kyphosis to see if it's rigid or not.
Okay.
And then I would go for osteotomies all over the thoracic spine and probably get fixation from T2 till L1 or even L2.
How can you choose the lower level in this case? L1, L2, maybe some surgeons try to go to L.
Yeah, I look to the first. I mean, it depends also on because where the lumbar hyperlordosis is compensation. I think we agree for that. No.
Yes.
Yeah, and I don't want to sacrifice too much levels in the lumbar area. She's young, yeah. How old she is?
She's 22.
Yeah. So I think I will stop in L1 or L2. Yeah, not lower than this. Some would go to the horizontal vertebra, which is L4 here or L5 even.
Yeah. Okay. Yeah, Ahmed, can we see what you have decided?
Well, actually, to add for this, I am always doing in these kyphotic patients the push-prone X-rays, to see if it is flexible or not. And actually, I decided actually for being immobile disc spaces and rounded kyphosis to do gradual correction with multiple ponti osteotomy and facet resection. What is this? Can you see the X-ray, or it is just green as I can see it?
Just green.
Oh, I don't know why. It was fine. I don't know what happened. Okay. Anyhow, I did ponti osteotomies for the case, and to correct the deformity, and no.
Okay, excellent, very good.
And
how many
actually about the level of the ending your fixation, I believe that it is much dependent upon the sagittally stable vertebra more than using the first lumbar lordotic, the first lordotic disc, because I have passed before with many experiences where I'm trying to save mobile discs, and then it ends after with insufficient correction and some adjacent segment problems, and so I always follow the stable sagittal vertebra. Here we can find in comparison for the previous parameters, the angles, the pelvic parameters, that the condition is much more corrected, the lumbar lordosis, the thoracic curve, as well as the thoracolumbar junction curve is reduced back to 15. And I think that you want to ask about anything?
لا تمام.
Yes, may I have comment, Dr. Magdi?
Yes, Dr. Muhammad.
Yes, please. I would like to ask Dr. Ahmad Badrawi about the flexibility of the curve and the age of the patient. If the patient have flexible curve, I mean you can achieve good correction by the multiple ponti osteotomy. You can stop a little bit higher up. But if the curve is rigid, you have to correct by doing sacrificing one or two vertebra from the lumbar curve, although it is mobile, yes. But if the curve is not completely corrected, we have to extend our feet, because if it is rigid, we have to extend our fusion a little more down. What about his comment on that?
My comment, actually about correction and level of fixation, I think it's not so much dependent upon the mobility more than to have a stable end of the fixation. I mean, okay, it is mobile, so that you can correct by this type of posterior column osteotomy, but the level of fixation, unless it's totally compensatory curve, I mean in the lumbar spine, I think we should stop at a fixed level. I mean, the most stable sagittally stable vertebra, which
but
I
this
think
can
here
take you
is
down to the L4. This can take you down to L4 in this case, like Dr. Asakir have said. If you run about the stable vertebra, you may come down to L4, and this is not good for a young girl. So I think the curve mobility.
Yeah, if it is like the stable vertebra would be 5 or 4, then I would think about it. But I think 2 from 3, it's not a big deal. And I think as well that
I think in this patient you chose the correct level, because the sagittal stable vertebra in her is L4 actually, and
it's a matter of balance.
You cheated one level above, which is you saved the level. So technically, the stable vertebra in her is L4, which is, you know, by definition the most cephalad bisected vertebra. But in your case, because she's young, you cheated by one level too. But if you pick L2 or L1, it will be way off, and she will decompensate. So I think the minimum is to do L3. Yeah.
I mean, all
especially
of us,
in kyphosis, in kyphotic deformities, she will decompensate easily.
in all of us actually are always faced with this situation, whether you will go to fix more, or you will lose the correction, or you will get incomplete correction and off balance. And at the end of the story, you do that balance, I think. So this case, I would follow with another case with as well-rounded kyphosis, but with different situation. In this case, the disc spaces are immobile because the patient is having ankylosing spondylitis. And the difference is that we have to extend the way of correction, I mean the osteotomy, to the anterior bony body to improve the correction, because in this situation, ponteosteotomy wouldn't help because of the immobile discs. As we can see, it is like maybe 20 centimeters of the sagittal balance forward, and in the angle of the dorsal kyphosis is almost 85. So intraoperatively, we go for inserting the set of the pedicle screws, compression of the required levels, then under image intensifier, we put the set of 2 osteotomes, one parallel to the end plate, the other with a triangulation proper for the angle of the correction. And this was the end result. Actually, I would like to here to notify that in usual way for pedicle subtraction osteotomy or the classic pedicle subtraction osteotomy, you get losing the connection between the vertebral body and the posterior element. So it becomes unstable vertebra. Some of us will add caging or interbody fusion to protect forward or lithosis later on. But with Professor Dr. Wafa, we managed like many cases with modifying it. You doing what is called the partial pedicle subtraction osteotomy, where we don't completely resect the pedicle and keeping some part of the pedicle to connect between the posterior element and the vertebral body. In these situations, the correction might be less per each osteotomy. So you have to add another one to get sufficient correction. This is another different case scenario with a congenital kyphosis in 11 years old child. We can see here that we have congenital 3 successive widget vertebrae, the number 7, 8, and 9. And due to the sharp deformity, I think the most proper type of the resection would be the multiple vertebrectomy or the PCR for the 3 or 2 of these segments. So intraoperatively, as we all know, we go for circumferential anterior, posterior toward anterior and lateral dissection of the vertebral column all around, exposure of the sides of the vertebral body, securing the vessels, as well as sometimes we need to sacrifice the roots. After the circumferential decompression of the spinal cord, we can use the sacrificed roots as a gentle joystick for the cord and go for the posterolateral dissection and access the vertebral body through costotransversectomy. And here we can remove the vertebral body in a piecemeal with temporary rod, which is placed in the deformed position. And then to the other side till we get completely freed the cord circumferentially and resecting the segment. And here we can see the pleura. We are going like extracavitary approach. And then the final position of the correction. At the end of the story, you should reconstruct the anterior column as well, because in such cases, we have to restore the basic biomechanical rule of the spine implants, that the anterior should be for the pressure bearing while the posterior is behaving as a tension band mechanism. And this could be achieved from the posterolateral approach through placing the mesh cage from the posterolateral approach through the developed space by the corpectomy and the laminectomy posterior. And the mesh cage actually should be always controlled during the steps of the surgery till it is totally secured with some stainless steel cable or some strong ethy bond not to be lost inside the thoracic cavity. This is the follow-up after 8 months where we can find anterior good fusion to the mesh cage and lateral as well. Another type of osteotomy, which
Ahmed, can we go back to this case, please?
Yeah, sure.
There was a modification by Professor Meshtawi. Do you know the Professor Meshtawi from Asyut University?
Yeah.
He was able to add an anterior screws to this vertebra from the posterior exposure, and to control the cage also. I don't know, Professor Meshtawi. I think he is hearing us.
He was online with us.
Meshtawi, are you here? Ahmed, can we ask Dr. Meshtawi?
I think he left the meeting, maybe.
He was able to add anterior screws. What do you think, Ahmed, in this technique?
Well, actually, yes, I have met Dr. Meshtawi many times, and we were talking about VCR, and he said that. But my comment about it, that why should I take more time, especially in these ultra major surgeries, for inserting something anterior? I know it might be more supporting, but actually a well-fitting pyra mesh for the space with some compression from posterior would be enough. Why should I think it needs a long time to do this, and it might have some long time learning curve. I didn't try it, but actually any step would lengthen the surgery. For me, I won't do it in these cases, especially.
Okay. Yes, please.
Magdi?
Dr. Muhammad. Dr. Muhammad? Okay, Ahmed, go on, please.
The last example for the correcting osteotomies is that limited type of kyphosis, where the angle is very limited and you have a neglected fracture like this one, L1 fracture. This patient presented to me after 8 months from the developed trauma. And actually, I would prefer to use in these cases the bone disc bone osteotomy, where you remove the disc above and flatten the vertebra from being wedged to be flat, so that it could correct the sagittal balance or the localized angle here. As we can see here, this is after. You don't need much long segment fixation. It is just limited above and below. And it is flattened here. With removal of the disc and putting bone graft, you are enhancing the fusion in short time. So I think it is better than using other extensive ways of osteotomies to correct the situation. And actually, what I want to give as a take-home message for colleagues is that we know that human is a bipedal creature. So always the human body is trying to keep the upright posture. Whether you have the kyphosis, kyphoscoliosis, whatever the kind of the deformity, the body will try always to keep you upright. And this is on the expense of many things, because the main aim is to have your field of vision wide and free. The upper limbs are free for tasks, and to optimize the body axis so that the muscle effort will be less, and subsequently the energy expenditure. The efficiency conus of Deposé really, although it is very basic, but I think it is very intelligent to summarize the consumption of the body, that he summarizes the biomechanics of the human stature in the cone theory, where the apex at the foot or at the feet, and the base of the cone at the head level. And then inner core cone, which is near to the body core. And so long you are inside the inner core, you get the economy balance, where the body is in the upright position without consumption of a lot of energy and muscle effort. And when you go to the outer cone, even during exercises, when you exercise while flexed or bent, you will feel that you are exhausting yourself easier. While if you are upright, there is much less effort to exercise and the expenditure is less. The parameters we talked about and before, I want just to concentrate upon some points. For example, the T1 tilt. I believe that the T1 tilt of the thoracic vertebra, the first one, it's very important parameter for the sagittal balance. I believe that we have to restore and not to keep only thinking about the region of the deformity. The thoracolumbar junction is very important to reestablish the sagittal balance. I believe as well that the lumbar spine parameters should be, and actually it is very important in our work, should be subdivided into three main curves, the upper one, the middle one, and the lower one, because actually the upper one is much affected by the pelvic incidence changes than the lower one or the more proximal to the pelvis. And that the middle one is very crucial for the correction of the deformities of the lumbar spine, and is very crucial to place the osteotomy at this level. And I think this is the most important home message or take-home message that I would like to deliver, that the body is compensating and gaining a lot of problems because of this. It's not only the spine. You get arthritis of the hips, the knees, even the foot. The gastrocnemius is exerting a tremendous effort in order to keep the knee flexed and the ankle a little bit in extension in order to keep the body in such posture. Lastly, to summarize, the realigning spinal osteotomies are classified according to Schwab previously into the posterior column osteotomies like the Smith-Peterson and the Ponti, then the pedicle subtraction osteotomy, the modification of the pedicle subtraction, the bone disc bone osteotomy, and the vertebral column. There are more classifications, but I don't think that it is so helpful like Schwab. I think it's complicated a little bit, and Schwab is easy and it's doing the job. And actually, I would like to stress over this slide, which is the selecting criteria for which type of osteotomy. We have to think about the kyphotic curve to be one of these categories. The type 1A, where you have a deformity with no column deficiency. It's mobile, flexible discs like in Sherman. While 1B, it is the same, but while the discs are immobile. 2A, there is anterior column deficiency. 2B, posterior column only. 3A, both columns are affected, and 3B, both anterior and posterior with greater than 60 degrees. And the last and the most morbid, which is 3C, with buckling of the spinal cord, the vertebral column. And there are many selecting criteria for correcting the deformity, and I would like to stress about the curve pattern, especially if we classified them to these categories and subcategories we mentioned before. It would help a lot to select the proper type of the used technique. Thank you so much. Thank you.
Thank you very much, Ahmed. We are running out of time, but we have Dr. Mishtawi is here. He wants to comment on his. Mishtawi, can you unmute yourself, please? Dr. Mishtawi.
Yes, Professor Magdi.
Hello, Mohammed. How are you?
Yeah, good night, everybody.
Professor Mohammed Mishtawi is a professor in Asyut University, and he's one of the pioneers in osteotomies in our country. So please, in few minutes, Mohammed, tell us your technique and what's the advantage that you have mentioned in your techniques.
Yes, Magdi. It is very nice delivered by Professor Badrawi. I think he did the best. The anterior screws I wouldn't use in the mid-thoracic region. I use the anterior screws in the thoracolumbar junction when the apex is at the thoracolumbar junction mainly. It helps not in the correction or stability alone. No, I put it primarily because I see that these curves, these congenital kyphotic curves above 90 always have a torsion, and the upper part of the spine doesn't meet the lower one in 3D. This is why I put the screws. Every screw is directed parallel to the trajectory of the upper part and the lower part, And what I made by these two screws is just to derotate the spine and make it meet with parallel end plates. And this is a primary goal of putting the screws anteriorly. Many spoke about the lordokyphosis and the kypholordosis theories about the congenital thoracolumbar kyphoscoliosis, and there is no evidence that there is kyphosis within this region unless the apex of the widget vertebra. What is around the congenital kyphotic apex is a lordotic spine, and this lordotic spine rotates around just to make it stable. And the only way is to unlock this torsion by rotating the spine against each other to make a stable spine. Magdi?
Yeah. Thank you very much, Mohammed. Maybe next webinar you have to be with us. You show your technique and you add to our faculty, please. Thank you very much.
For sure, Professor Magdi. Thank you.
Thank you very much, Mohammed. Now we have Dr. Ali Mazyed. And by the way, Dr. Hussein Al-Gafi is here with us. Okay. Dr. Hussein is.
Could you unshare the screen, Dr. Badrawi, so I can share mine?
Dr. Hussein Al-Gafi is with us. Please interact with us, Dr. Hussein, in any questions, any interaction. Please let me know, and to unmute yourself and be free to ask and interact and give us your experience in this topic. Ali?
Yes, I can't share my screen. Can Dr. Badrawi unshare his?
Badrawi.
I did. هي لسه ظاهرة عندكم بيه أنا شلتها.
Yes.
أحمد. في أحمد.
يا دكتور مع حضرتك.
دلوقتي can you see this problem?
Okay.
دكتور بدراوي. اوكي خلاص.
Okay.
يلا علي.
I stopped it خلاص.
Okay, now it's working. Okay. Let me start. Can you see the screen now?
Yes. Yes.
Okay, good. So thanks for having me tonight, among the great faculty. I'm trying to be on time and quick so that we can get going. So my talk is going to be pretty simple to cap up what's been talked about. So I'll start with this patient, a 60-year-old patient with a long history of low back pain and neurogenic claudication. And she had prior decompression from L1 to L4 a year prior. And she comes to your clinic. It's pretty common that you see somebody like this. And I just wanted to put this so you have a thought process in your mind. Do you get more investigations? Do you do discectomy? You do fusion? What do you think about from that point forward? Whatever you thought about, the patient actually had a fusion elsewhere from L1 to L5, as you can see it. Can you see my cursor?
Yes, yes.
Okay, so the claudication improved. But she still has constant back pain standing and walking. So if anybody has any comments, or I can just keep going, up to you.
Let's continue, Ali.
Okay.
Yeah.
So after having 2 failed back surgeries, you should start thinking about inadequate decompression, misplaced hardware. She has pseudo, you get a CT or infections or other problems. And in her case, that should be what you think about. Her key problem or key point to think about was she fused with adequate lumbar lordosis. And if you put the measurement there, she only has 28 degrees. And unless you understand the pelvic parameters, you would not know whether that 28 degrees is enough for her or not to have a balanced spine. So as discussed, the economy, I'm not going to go through it, but you basically need a lot of muscle fatigue and a lot of extra effort in the extremities and lower back to stay within that economy. And usually you would consider other investigations, x-rays, MRIs, labs to rule out infection. But the goal here is to always think about the overall sagittal parameter. So in this patient, she had pretty well decompressed at the L3-4 as compared to prior, but her back is still seems with less lordosis. So if you get the full length X-rays, you could see that she has a pelvic mismatch, pelvic incidence lumbar lordosis mismatch about 33 degrees. She has a pelvic incidence 51, and the SVA is about 11 centimeters. So before I go, I'll just go through a similar patient who has the similar flat back syndrome following a prior fusion. And as we know, the normal range of lordosis, at least the individual patient goes, should be between 40 and 60. But in her case, it's 21 degrees. So she almost has like a rectangular spine from T12 to L5. And that patient, again, you get a full spine X-ray on them. I'm trying to stress that point because it's not the commonly thing done. I usually get a lower back spine X-ray. And in her case, you get a flexion extension. You can see that she has some pseudoarthrosis at L1 to...
Ali,
yes.
Can you please don't show what you did? You just finish the parameters.
Oh, okay,
let us,
sure.
Let us
no
discuss
problem.
the case with Dr. Jeffrey and Richard, and Dr. Hussein Gafi is with us also.
Sounds
We
good.
would like to hear from him.
Okay. So I'm trying to get down to the basics because some of the audience may not know how to do it.
Take your time.
Okay, the key point is to know how to measure the pelvic incidence. So in a lateral X-ray of the lumbar spine, you want to identify the midpoint of the upper sacral S1 and the midpoint of the femoral head. And that's where or how you will measure all the parameters of the pelvic spine. So to go through it quickly, the pelvic incidence is a constant anatomical value. It does not change once the person reaches skeletal maturity, does not change with position or spine deformity. It stays constant. The only way you would change a pelvic incidence if you have a pelvic osteotomy or some kind of a pelvic fracture. And the sum of the sacral slope and the pelvic tilt is the pelvic incidence. So this is the mathematical sum of the pelvic incidence. The pelvic incidence is the mathematical sum of the sacral slope and pelvic tilt. And so in a patient like this, I'll go again through the measurements back to basics. So if you want to put the lumbar lordosis in this patient, again, this image is cropped. It's supposed to be full length spine X-ray. So from L1 to S1, that's your lumbar lordosis. You get the pelvic incidence. Again, I'll show you how from midpoint of the upper end plate of S1 to the femoral axis, and then the perpendicular to the S1. In her case, it's 48. Circle slope is 20 degrees, and the pelvic tilt is 28 degrees. So once you measure those, you want to see the mismatch, and in his case, it's 27 degrees. So that's how much lumbar lordosis this patient would require to stay balanced when standing. So you want to estimate your target. That's based on prior research by Schwab, is that the lumbar lordosis, your target should be within 10 degrees of the pelvic incidence. And that's a pretty crude measurement. So roughly you want to get 55 degrees. So the mismatch, if you want to get an extra 35 degrees, then that's when you think about the kind of osteotomy you want to do. And obviously in a fused spine, the one thing you can use is the pedicle subtraction osteotomy, plus minus a PCO, which again combines the Ponti and the Smith-Peterson. Now it's called PCO, or posterior column osteotomy. So that would be my plan treating this patient.
Okay, let us.
I don't know if if the other audience have something else to say. Yeah.
Jeff, are you here, Jeff?
Yes, I'm here.
Yeah, let us see. Let us listen to your opinion, please.
Do you have the full length film on this patient?
I did not put it particularly in this patient. It's in the next one. I was just trying to put the measurements on this one on a, what do you call it, like a cropped view. But the next one, I have the full image. So sorry about that.
How old is this patient?
55.
55. Okay, so they're young.
Yeah.
Yeah. So I mean, you can certainly do a PSO, and I think it would give you enough. It would give you enough correction, and you could. The thing that we've been doing a little bit more lately is doing anterior posterior, and so if we got a CAT scan, make sure the disc spaces are open, the sets aren't fused. Whenever there's a previous posterior fusion, you just want to look and make sure the facets that hasn't fused beyond where you've already fused it. because sometimes you say, well, the instrumentation goes down to L4, but sometimes the bone graft is fused over to L5 and it's not a mobile segment. But something like this, we might consider doing a 2-level ALIF, L4-5, L5-S1, and that would give us a certain amount. You talk about these hyperlordotic cages. It's hard to fit like a 30-degree cage in there.
Right.
So it's not really realistic to get 30 degrees from one level. But, oftentimes you can get a 20-degree cage in at L5-S1. At the very least, you can get sort of a 15-degree or something like that. And you might be able to get enough correction in L4-5 and L5-S1. And then if you go in the back, you might be able to do some facet resections up in the upper areas to kind of give you a little bit more, and it might give you enough to put a patient back into balance. You could always consider doing a lateral at 12L1, and that may give you also a little bit more. But I bet you could do a lot of this with posterior facet or Ponte osteotomies if you did the ALIFs at L4 to S1.
Okay, that's another way of doing it.
Yeah. Richard. Hello.
Yes, I'm here.
Yeah. Can you tell us? Do you agree with Jeff, or do you have another? Or do you agree?
I would take the second option of Jeff. I would go anterior. I mean, I need a CT scan to make sure that the fusion mass is not going over L5. And if I have vacuum in vacuum of S1, this would be excellent for an anterior access. And I will go anteriorly with ALIF 4551, then go posteriorly, take out the instrumentation and realign it with PCO. I'm almost sure that a PSO is not needed in this case, and I always try not to go for PSO.
Okay, you are using the discs instead of going with the bone.
Right.
Dr. Hussein,
Would you be concerned about if he's a younger guy, he's 55, but maybe a little younger, would you be concerned about retrograde ejaculation or something like that, doing an ALIF?
Yeah, this is a big problem in the Arab world. Yeah, I know that. But yeah, I would consider this, of course. I will tell him, and he has to accept or no. If he's hesitating, I would not go anterior, of course. But you can also go lateral ALIF and OLIF at 5.1 and 4.5, which is safer for retrograde ejaculation because you go really behind the arteries and the vein, but you have to assess this.
This patient was done before the OLIF era, so there was no OLIF back then.
So ALIF and then and if she refuse an anterior access, I think a very good PCO would be enough.
Hello, Hussein. Dr. Hussein. Dr. Gafi from USA. Hello, do you hear it?
Yeah, can you hear me? Yeah,
yes.
I can hear me.
Hello, Dr. Hussein. How are you?
Good, very good. I'm happy to hear you after that long time. And just to comment on this case, actually, I have a similar case.
Yes.
And what I did for her, I went because I think. Hello, can you hear me?
Yes, Dr. Hussein.
Hello.
Yes.
So what I did for her, because I heard your concern about the ALIF and retrograde ejaculation. Actually, I correct her all from the back, and because majority of the lordosis in the lumbar spine, about 25-30 degrees, come from L5-S1 disc. So I did TLF, and we used a big cage from the back, and with another TLF at L4, went down to her pelvis, put iliac screws, and she corrected very well.
Okay.
So I think that's a good option if you consider going to the pelvis and do big TLF at L4-5, L5-S1.
Okay, so now Thank you, Dr. Thank you, Dr. Gaffey. So now Dr. Gaffey wants to do this, the whole job from the back, while Dr. Jeffrey Wang and Richard advised anterior for a bigger lordosis degrees. What did you do, Ali?
So let me just go by again how I slid in that X-ray again how to measure the pelvic parameters, and this is just a schematic of how it's done. Pelvic incidence, and that's the pelvic tilt and sacral slope. So so after planning the osteotomy, a patient like this, I usually use SurgiMap for planning osteotomy. Again, that was before the KIOPS. And she has a 21-degree lordosis. And if you plan a wedge of about 35 degrees at L3, that should get you enough lordosis to meet your target. And I thought it was, a single level lordosis because, trying to do a PCO through priorly fused segments that are collapsed is not that easy. You may not end up with any correction at those levels, and then you wonder what to do. So in her case, we did L3 PSO and PSF10 to pelvis, and that's her correction post-op. Again, that's cropped from a full-length X-ray to show the thing. And his back pain was gone, and his ODI improved. And you could see this is the preoperative planning, and it's almost identical to what we had. Again, going back to the importance of planning those deformity cases. And pelvic incidence obviously the same, but he went from 25 degrees to 56 degrees with a single level PSO. I'll go through another case. I know the time is running. This is a more complex patient, 59-year-old patient with low back pain and unbalanced walking. She had the Harrington rod fixation from D10 to L4 many years prior, and she's decompensated both in the coronal and the sagittal plane. And that's her imaging study. I think Jeff might be more interested in this one. Now it has the long film. Dr. Wang?
Jeff. Hello?
Oh, sorry.
Yeah.
So, so how old is this patient?
59. Yeah, 59.
Okay, and they're already fused, previous fused down to L4.
Right.
And so that's the standing view. So it's solidly fused. I'd probably get a CAT scan just to.
Oh, she's solidly fused. She had that fixation when she was like very young, and so she is solidly fused. You could see all the bony mass in this area here, and it's overlying the rod. And we definitely got a CT scan. It was completely fused. You can see the bone right here too. So
it looks fused. It looks like it's fused all the way down to L5. Is it fused
pretty much
S1, or is it just
I think it was I think that the bottom of L5 I think 5-1 was spared, but you know that bony mass is all over the place.
Yeah. So I'm not sure, oftentimes we will go front back, sometimes just to get a nice graft at L5S1 just to help with the pseudoarthrosis rate. If the patient's healthy and they don't have vascular issues, especially at L5S1, we actually think we can do a nice ALIF. We can use BMP sort of on label going from the front, and that kind of gets rid of the potential for pseudoarthrosis. We feel a lot more stable, and so we might do an ALIF and probably try to get a hyperlordotic cage in there, maybe get 20 degrees of correction there. It's not horrible as far as the amount of the C7 plumb line. I mean, it's
not too bad.
Yeah,
she's more really unbalanced than Saturday. I agree.
Yeah,
but she was in a lot of back pain, and you could see her pelvis is pretty. I mean, her sacrum is pretty. She's on the verge of decompensation.
Yeah,
her sacrum is pretty vertical.
So I think you would probably have to do like sort of an asymmetric.
Let me put the measurements to help you out a little bit. Yeah.
Okay. And where's her lordosis? I'm sorry.
What it is, it's about 32 degrees. Again, you know, this is, yeah, it was about 32 degrees lordosis.
Yeah. I think, you know, we might still consider doing an ALIF at 5.1 just to get that nice graft in there at 5.1, and that would help with the osteoporosis rate. But I think you probably need to do like an asymmetric osteotomy just to correct some of the coronal deformity.
Right.
But you have to be careful. You don't want to overcorrect the patient, especially if you do that ALIF at 5.1. I mean, that's going to give you a lot. And then if you try to get too much with the PSO, then you might overcorrect this patient.
Exactly. That's true.
No, this is
so this is so actually I did this in fellowship. So if I'll show you what we used back then. So so the plan was T4 to pelvis, L3, asymmetric PSO, and at that time we used XLIF. I don't know if you ever used it, but so again, planning the osteotomy, again, just like Dr. Wang said, you don't want to overcorrect them in the coronal plane or the sagittal plane because she didn't have that much deficiency. So that was her pre-op. We planned about a 30-degree wedge in the sagittal plane, and that corrected her to about 60 degrees, way pretty congruent with her pelvic incidence, which I recall was 44 degrees. And in the coronal plane, we got, you know, a little bit of correction, about 20 degrees. You got her coronally balanced as well. So that was it, the final X-ray after correction. That's her pre-op plan, pretty close to her post-op. And again, in the coronal plane, it was pretty close. So those are the two cases. I'll just run quickly through a few slides to, you know, get some of the concepts to the audience. Yeah, you should aim for a sagittal balance, obviously, as everybody talked. The SVA is associated with below 5 centimeters is associated with better quality of life measures. Once you get into sagittal imbalance, you start to compensate from the pelvis, from the knees, with the hypokyphosis, flexion of the knee, extension of the hips, and retroverted pelvis. It's important when you get X-rays to assess those patients to try to get them standing straight, because this will throw you off if they're bending their knees. And you can always use it on a total hip. That's not a problem. The parameters can be measured. But this shows you the sequence of decompensation or compensation of the patient. And this compensation is relying mainly on how much of a pelvic incidence they have, because as the pelvic incidence increases, their ability to compensate increases. So the value of the PI is very important in those patients and can get them a good compensation. Hip flexibility also, because that's how they get extension. If they have arthritis of the hip, they can't extend it, they might decompensate faster. And obviously bending the knees and hypokyphosis. Pelvic tilt is also associated with decreased quality of life measures as it increases. And you can see here, this is a patient with a normal pelvic tilt and obviously a flat back. They are looking down. So to compensate, I mean, to look forward, they start bending or retroverting their pelvis. And finally, once they get complete retroversion of the pelvis, they can look forward. But that's where you see the sacrum vertical. And as the SVA, this is a patient with large SVA and less and low PT. As the PT increases, the SVA decreases, but obviously their quality of life measures goes down. And this is the concept of the pelvic vertebra as a compensatory vertebra or segment to the spinal deformity. And post-op alignment goals, again, those are published by Schwab. And you want to get the pelvic tilt below 25, as Dr. Sacker showed, and you want to get within a reasonable range from the pelvic incidence. It's important nowadays to realize the age-adjusted measures. It's not just pelvic incidence plus minus 10. In older patients, we can get away with much more or much less correction, and that's actually for the patient's benefit. Overcorrection is associated with higher disability in older patients. And you can read this paper, or you can see that as the age goes higher, the mismatch actually is acceptable to be bigger. And also the PGK rates increase if you overcorrect those patients. Just like in this patient, you have almost the same age group, 65 years old. This has, age-adjusted parameters of the mismatch. She's very close to it. In this patient, same age, but she's overcorrected and she has a PGK. So it's, I think it's a very good article, this one, to look into and understand that overcorrection can have its complications. So finally, the take-home message is understanding the spinal pelvic parameters is mandatory for any spine surgeon because by definition, we are all deformity surgeons. Either we create them or we fix them. So if somebody's doing a fusion without understanding those parameters, might end up having a lot of patients with flat backs that require revision. Getting a full X-ray on a spinal fusion is a good idea. Particularly if you're doing more than 2 levels, and in those patients, it's very important to get the spinal pelvic parameters done. Age-adjusted parameters are important to avoid overcorrection and PGK. And last but not least, failure to plan is a plan for failure. So always plan those patients because deformity is challenging. And thank you.
Thank you very much, Ali. This is a very nice presentation. There is a question for you from Dr. Wisal Tawfiq. She is a consultant physiotherapy. She is asking you, what is the rule of the physiotherapy post-operative and what are the red flags that you have to be aware of after these big surgeries from physiotherapy points?
Well, I think physiotherapy is really important in any spine patient or any spine surgery, pre-op or post-op. So I think pre-op conditioning is important for those patients, especially if you're doing a big deformity, because the stronger their muscles are, the more prepared they are to walk and get out of bed, the faster they recover from surgery. So that's doing pre-operative physical therapy is important. And post-operatively, obviously, like, when we did those patients in fellowship, you need to get them out of bed the same day. So that's when physical therapy comes in. They don't get up on their own unless somebody helps them. So day one, you get them out of bed. They have to follow certain milestones in order to get out of the hospital. So they need to, walk independently or with a walker, be able to do the stairs. And if they can't, they just don't go home. They go to a rehab facility until they reach those milestones. So I think physical therapy is extremely important in any spine patient, one particular deformity. Did that answer the question?
Yes,
or
thank
did
you,
I miss
Ali.
something?
Yeah, thank you very much. Any comments or questions from the panel? Professor Wafa, Professor Mazyad, Abdel Fattah?
Yes, please.
Yes, Dr.
I
Muhammad.
would like to ask Dr. Ali about the compensatory or compensation mechanism at younger age group as compared with the elder geriatric age group.
Okay, so in younger patients, and by young, we gotta define young. Young, is it 60 years old? That's relatively young, or young like 40-year-old with a like post-TB kyphosis. So younger patients with flexible spines, obviously they have a better compensatory mechanism, whether in the thoracic or the unfused, undeformed lumbar segment. So if they have an L1-2 post injury deformity or post-TB, they will compensate in the lower lumbar spine and in the upper thoracic spine. But if they are like an older patient who had prior fusion or like iatrogenic flat back, then they have much less compensatory mechanisms. Also from the hips, if their hips are worn out or arthritic, they cannot tolerate doing compensation, or their knees is giving out. So I think the younger you are, the more compensation you can have. And obviously, it's very important if you have a deformity to treat it early on before you actually ruin all your other defense mechanisms, such as your hips or knees or proximal spine. So that's why deformity is, if somebody has a deformity, the sooner they do it, the better, before they have other adjacent segments having a problem.
Thank you.
Thank you, Dr. Muhammad. Dr. Wafa, any comments? Dr. Abdel Fattah? Jeff, do you need?
Oh,
Yeah, Dr. Wafa.
Oh, yes, doing very well. Right.
Thank you, Ali, for
Thank you.
Very nice presentation.
Professor Saud, I miss you. We haven't met in many years.
Yeah, that's right.
Professor Saud
right.
was my mentor and advisor both on the master's and the PhD. So, you know, he helped me a lot through many steps in my career. Hope to see you soon
You've been
after
one of
Corona.
my best fellows ever. And you've been one of my best fellows ever.
Thank you. Thank you.
Okay. Now I think we are running out of time. I was asking Professor Jeff, one time we worked together with Richard Asaker, also in AO Spine for a long time. We had great time together. And I was asking Jeff, how could you reach these positions? You have been a resident, and then you reached the head of the AO Spine, the head of the NAS, and the head of the cervical spine research. We need to listen to you about the leadership skills. So it would be an interesting lecture, and we are keen to listen to you, Jeff, about this. Can you start this lecture?
Sure. And I will try to be quick because I know we're running out of time.
Okay.
Can you see my slides?
Yes.
Okay. So these are the five areas I want to talk about. Well, actually, you know, as training, especially for the young surgeons, we learn how to treat patients, we learn how to communicate with patients, and we learn how to do surgery, and we learn how to manage complications. But the two areas just worldwide that we think that we're deficient in training young surgeons is financial management, which I'm not going to talk about, and leadership development. And I think these are both very, very important, especially for the young surgeons. And so when I look at leadership development, I think it's so important, especially with all the societies. But if you look at what makes a good leader, it doesn't have to be with NAS or with AO Spine. A good leader can be a good leader in your own department. It could be a leader in the hospital, your regional society, or your national society. And so just being a good leader, I think, is something everyone should strive for, because you're going to lead your team. Even if as a surgeon in the operating room, you're leading your operative team. You're leading the anesthesiologists, the nurses, and the residents and fellows. The last thing to understand is that these are just my opinions. There's no science there. And so I'm going to talk about these three areas. And I think these are the keys that I found are key to leadership. Number one is understanding other people's perspective and to think globally. And what I mean by that is that this is a cartoon. So from this guy who's on an island, he's been stranded, he thinks he's going to die, and he sees a person in a boat and he thinks he is saved. Whereas the person in the boat has been adrift at sea for days, and he thinks he's going to die, and he thinks he is saved when he sees the land. Here is a situation where two people have different perspectives. And I think whenever we go through our life, whether it's something that you go in the hospital, you're dealing with a patient, you're dealing with a nurse, or you're dealing with a committee, with a society, or people at your hospital, everyone is going to look at a situation that's clear cut, and they're going to have different perspectives. And I think a good leader tries to understand other people's perspectives beyond their own. Now this is a little bit different. This is an optical illusion. If you look at the person on the left, he sees 4. The person on the right only sees 3. So this is another example of people having different perspectives, but the difference here is the situation is very unclear. And when you think about it, especially when you think about politics worldwide, or even politics within societies, or even when I go to the operating room later, people are going to have an unclear situation and people are going to have different perspectives. And I think the key is to understand other people's perspectives. And so it's kind of interesting. I was watching a movie, and on this movie, a person had died, and they were clearing the body, and all the police were in the house. And I looked on the wall, and there were all these photos. Now, these photos, in the context of that movie, no one really cares about the photos. People are wondering about this person dying, and the police are there. And these photos belong to the person who passed away. But you know, to us, we look at these photos, they mean nothing. But to that person who lived there, these photographs mean everything. And so this is an example of my house. And I can tell you here is in my family room, and there are pictures, and this is in my laundry room. And if you walk by these, you would just sit there and say, well, these are just pictures, right? But for me, these mean more to me than anything. This is my family. And so you and I would have a different perspective on a situation like this. And that's, I think, a situation we often find ourselves in. Now, I'm here in Los Angeles, and I probably have a California perspective, or at least a United States perspective. And I think you in Egypt probably have a different perspective. But the key is to try and understand other people's point of view. You may not agree with it. You may feel like your point of view is right, but you at least need to understand the other person's perspective. And so I won't go into detail. I can tell you in NAS, there's so many controversies. And I can tell you that running the NAS Society, last year when I was president, it was one of the most difficult jobs. But I can tell you that what I did was basically look at the data, and I realized people had different perspectives. People thought NAS was mainly attended by non-operative people and not surgeons. And when you look at it, there are only about 100 to 200 non-op people. There are thousands of surgeons that attend NAS. And so people may have a different perspective that might not be right. So my advice to people is think globally, think about how your comments may impact others, your decisions, how it's going to impact others. The most difficult thing is self-awareness. You know, it's hard. We always think that we're great and that what we're saying is right. But oftentimes we don't take time and sit there and say, how do other people perceive you? You know, especially in today, and I don't mean to criticize the young surgeons, but I think people today, just in general, at least in the United States society, they're very self-centered. And what that means is they view the world from their own point of view. And it doesn't matter whether we think we're right or they're right. We just have to understand their perspective. They're going to look at things and how it affects them. And it's important to understand that. And I can tell you that one of the initiatives I drove when I was president of the CSRS was to allow international members to become full members of the Research Society. And I had to understand the perspectives of people that were already members and didn't want to allow international members in. And so it really helped me to think globally. And that's something that's really helped me. The second thing is what makes a good leader. You know, if you Google leadership, you get a lot of different pictures. It's usually the person standing in the front, and there are a lot of books on leadership. But the important thing is that even though we're all different people, if someone asks us what makes a good leader, I bet we would all get some of the qualities right. If we had to each individually describe what would make a leader a good leader, I bet we would have similar attributes, we'd have similar principles, and I would bet that if we had to write down 10 things that make a good leader, we would probably have 5 or 6 that are probably on everyone's list. And you look at these people here, they're very different people and they're different personalities, but they're all good leaders. And when you look at this slide, these are people that lived in different times. They spoke different languages and they were from different socioeconomic areas. But I would bet that each one of them has some qualities that help them lead people that would be the same. So there are some principles that we can all try to learn to help us be a good leader. And you look at the world leaders, the world is vast and everyone has a different economy, different language, different customs. But I bet the attributes of making these people good leaders are probably the same. You know, what will make people listen to be a good leader? And so oftentimes we think it's the person out front, but sometimes a lot of people feel the leader should be the one in the pack, that shouldn't be the one out in front. And that they should be a leader, but they shouldn't be ostentatious about it. They shouldn't like wear the crown and say, I'm the king. They should try to sit there and be more subtle. I'm going to leave you with my personal advice. And I can tell you, this is what worked for me. I don't know if it's going to work for you, but it helped me become president of NAS. It helped me become on the executive board of the American Orthopedic Association. I'm the past president of the Cervical Spine Research Society. I'm the past president for the Society for Brain Mapping and Therapeutics. And I'm currently on the AO Foundation board. And I can tell you, this is what has helped me. And again, it may not work for you, but I always try to listen to understand. There are so many people, when you're talking, they're not listening to you. They not really understand what you're saying. But at the same time, you have to make your points efficiently. If you take too long to make your points, people are not going to understand them. if people interrupt you, they did not understand your points. And so if I'm talking and someone interrupts me, then I know they didn't quite understand what I was saying. On the counterpoint is if I interrupt them, then I haven't listened to them and I haven't gotten all their points, and I have to understand that. The other thing I always tell people, which is the hardest thing, is to show no emotion. There are times where you're going to walk in the hospital, you're going to walk in the operating room, you're going to walk in your department, where if you're in a society, things are not going to go your way. Maybe you didn't get a position or something, and you're going to be very angry, upset, or very sad. I always say, don't show any emotion. People can sense when you get emotional. Don't show your emotion. On the counterpoint is that you can show emotion when needed. And I can tell you that during my presidency of NASS last year, there was one time I showed emotion, and I did it strategically. And when the people saw it, they knew it was unique, and they knew I really meant it. And it was a point I really wanted to drive through, and it helped. But if I had showed emotion all the time, it would not have been efficient. I always compliment people before I destroy them. And what I mean by that is that there's a nice way to criticize people. If someone is presenting a case or someone has a different point of view, you don't have to sit there and say, you're wrong. You can sit there and say, that's one way to do it. I understand your point of view, but here's another way to do it. You can always be nice. You can always be humble. Always speak appropriately. Use the correct volume, tone, and speed. It's not about how fast you talk. Sometimes when you pause, sometimes it drives your point home even more. So be aware of how others perceive you. Always think globally, try to learn other people's perspective. And I don't try to argue with people. I try to make them realize that they're thinking on a very narrow scope. They're not thinking globally. If someone comes to me, like one of the fellows, and says, we need to make this change because I need to do more cases here, I would sit there and say, well, I'm not going to tell you you're wrong, but I would sit there and say, well, how are the other people going to look at it? Are the other fellows going to think it's fair? If we let you do this, is that going to be fair to other people? And a lot of times you don't have to criticize their point. You can just criticize their logic and make them understand that they're wrong. And I always say, don't attack their stance, attack their process and logic. I use this book a lot, and Magdi, you probably have seen this book. This is a book called Good to Great, and there are a lot of books out there, but this one talks about good leaders, and they talk about level 1 to level 5. And the bottom line is level 5 leaders put the interest of the organization first. And that's the one principle. If you take home one principle from my whole talk, is to always put the interests of the organization first. And what I mean by that is, at any committee meeting I've been at, any hospital committee, department meeting, or even in society, everyone's talking. And when I was the young person and no one knew who I was, if I sat there and said, I believe we should do this because this is what's best for the organization, other people are trying to figure out what's best for them. But if you always put forth your points on what is good for the organization, people will see that as being valid. And that's a single thing that I believe has helped me guide me through all the societies. And if I had to say one thing that's helped me attain the leadership roles in all these societies, it's been being a level 5 leader. You have to put your selfish interests aside. The other thing is that you have to educate people on what being level 5 is. If you go to any organization, if you go to the CSRS, you go to NASS, you go to AO Spine, and you ask them to be level 5, every one of them will know what it means to be level 5. Because this is a point that when I was a leader, I drove this point home so that people in the committee understood when people were not being level 5. If there are some people who are too selfish to be level 5, it's okay. You can't change everyone. But what you can train everyone in the organization to do is to recognize people who are being selfish and they're not putting the organization first. And they will recognize people that are not level 5. And that helps people realize what's appropriate and what's not. And so again, those are my viewpoints. I just wanted, just as a disclaimer, that's a viewpoint from me being in Los Angeles in US. I don't know if this will help anyone else in other areas of the world, but that's what's really helped me. So my take-home points are, there are lots of qualities that I think leaders follow. I think you can figure out different ways to improve your own leadership. And the last point is, try to think globally. Think about how what you're saying will affect everyone else. And with that, thank you very much.
Excellent. Very nice. Very nice.
Thank you, Jeff. That's a very nice presentation.
Yes.
Thank you.
Excellent. Yeah.
You know, Jeff, I did a research fellowship at USC before moving on. That's a while back.
Very good. We'll come back sometime.
I'd love to visit you sometime. I will. I'll get in touch.
All right.
Yeah, and you, Jeff, you have to come again to Egypt.
Oh, I would love to. I had such a good time. I had a fantastic time.
Yeah.
Absolutely.
Yeah. Okay, thank you very much, everybody. Dr. Amr, we have finished the...
I am very thankful for our panel, Dr. Jeffrey Wang, Dr. Asakir. I'm very, very thankful for your this nice, very nice, although it is very professional, although it's very sophisticated, but I think it was a marvelous webinar. Thank you very, very much. This was the strongest webinar I have ever done in NCHAMS throughout the last 4 webinars. I'm very thankful. Shukran, Dr. Magdi. Thanks for the speakers, our speakers, Dr. Ali Mizyad and Dr. Badrawi. Thanks for the panel, Dr. Mizyad, Dr. Wafa, and Dr. Fattah Saud. Have a nice good night. ونأسف للناس لو كنا طولنا شوية، بس الموضوع كان يستحق الحقيقة. It deserves this time. Sorry for this long night. Okay. Good night all.
Thank you, Dr. Ram. Thank you very much. Thank you.
Thank you very much.
Thank you, Professor Jeff. Thank you very much, Richard.